Guys, welcome and welcome to Meteor Academy, one of the leading academy in training nurses in the nursing competitive exam as well as IELTS and CLEX and OET training. Hope everyone is doing well. How are you all? And as you all know that we are conducting this magical session continuously. Most of the students are watching this magical session, and the feedback from the students are really motivating us. Most of the students who are joined in Meteor Academy, either in Pondicherry or in Delhi, whatever it is, whether in the offline or online. So many students are got selected and they are working in service in all over India. We are really happy to say that, and thank you very much for continuously supporting us. So please join us if you want to clear the exam in the first attempt. Join us as early as possible. Join in Meteor International Academy. Offline, online, both batches are available, and in Tamil Nadu as well as in Delhi, we are conducting offline batches. If you want to join online, you can join online directly, and the details of offline, online, everything will be shared in the in this video in the descriptions. So let's begin the session. Welcome back to Magic Pill session. As you all know that Magic Pill MCQ series, we are continuously discussing very important topics which is previously asked, repeatedly asked in the previous year question papers, especially like NORCET, RRB, JIGMAR, all those things. So watch the video till the end. Not only you are going to understand the question and answer, and also you are going to get the additional points related to that particular question. So watch the video till the end. Definitely it is going to be very much useful for you. So let's begin the session. And the topic what we are going to discuss, it is from genitourinary system. Okay. So all the topics or questions, whatever we are discussing, even though it is considered as simple, many times repeatedly asked in the exams. Okay. So simple question, most of the students will make the mistakes. So understand the questions properly and then understand the rationale and give the answers. Okay. So let's begin the session. As I mentioned already, today the topic is going to be from renal system. So critical care scenario based NORCET pattern questions, which is already asked in the exams. The first question is, a 56 years old male with chronic kidney disease is admitted to ICU with confusion, muscle twisting. ECG shows tall peaked T waves. This is the key point. Always I used to say that in each question, we have to find out the key points. Whether the question is in single line or 3 lines or 5 lines, doesn't matter. Just find out the key points. In this first question, the key point what I got is tall peaked T waves. Okay, and his potassium level is obviously it is going to be high, that is 7 milliequals per liter. Whenever the potassium level is high, what is the normal potassium? 3.5 to 5 milliequals per liter. Milliequals. Okay, not in milligram, it is coming in milliequals. Okay, so 3.5 to 5 milligram is the normal one, but here the potassium level in the blood is elevated to 7 milliequals per liter. Because of that, the ECG changes is happening, that is tall T waves are appearing in the ECG paper. Okay, fine. So as a nurse, what is your priority intervention? The patient is in ICU, patient has chronic kidney disease, confusion, muscle twisting is there. So what is your nursing first priority action? And 4 options they have given here, like administer IV furosemide, that is Lasix, and administer IV calcium gluconate, restrict dietary potassium, prepare for dialysis. Understand the concept, guys. See, the potassium is highly elevated, so tall peak waves are there. The patient will get the complications like arrhythmias. So first we need to protect the heart. That is the priority vital management. Always remember, whenever the tall T waves are there, means first to protect the heart, because the patient are prone for arrhythmias. Okay, so first, in order to protect the heart, you supposed to give which medication? That is calcium gluconate. Okay, so that is the first management. Obviously, administering insulin infusion and dialysis, all those things are secondary and tertiary management. But the first and foremost thing is protect the heart. Followed by that, shifting the potassium to the tissues by administering the insulin or dialysis for washing out the potassium. All those management are secondary and tertiary. The first thing is protect the heart. That's why we selecting the option B, that is administer IV calcium gluconate as a correct one. Understand the concept? So the second question is, A patient with acute kidney injury, AKI, acute kidney injury, due to hypovolemia. Because of hypovolemia, acute kidney injury happened. Okay. And now the patient has the urine output of only 15 ml per hour. What is the normal urine output per hour? 30 ml should be there. If it is going less than 30 ml per hour, it has to be informed to the physician immediately. Understand? So because of hypovolemia, acute kidney injury, the urine output is reduced to 58 ml per hour and the BP is also very much less, that is 80 by 60 mm of mercury. Dry mucous membrane is there. On the whole, collectively, one point we are getting, that is the patient is having what? Hypovolemia, dehydration signs and symptoms. Okay. So what are all the management as a nurse? Initial nursing action, what we supposed to do? Let's see the options. Start dopamine infusion, restrict IV fluids, infuse isotonic normal saline, and start diuretics. Start dopamine infusion. What is the need of administering dopamine? Here it is anywhere related? No. See, we should not start the dopamine. The first initial nursing action, that is the key point in this question. Restrict IV fluids. Why to restrict the IV fluid? We have to infuse the IV fluid because the patient is suffering from hypovolemia, dehydration sign. And infuse isotonic normal saline. Yes, obviously we have to maintain the blood volume. For maintaining the blood volume, you have to infuse isotonic solution. The examples of isotonic solutions are 0.9% normal saline, and even ringer lactate is also the isotonic solution. But what solution we supposed to administer in this condition? 0.9% of normal saline has to be administered. Isotonic solution has to be administered so that the blood volume will be maintained, the blood pressure will be maintained, so that adequate blood flow will be getting to the kidney. The further damage of the kidney will be prevented. Understand, guys? To understand this concept, you should know about isotonic, hypotonic, and hypertonic solutions. Please understand that one, and then you have to solve this question. Okay, and start diuretic. Why to start diuretic? Already hypovolemia is there. If you are starting diuretic, again more dehydration signs will be there. So we should not start the diuretic. We have to go with what? Isotonic solutions only. So here the right answer is going to be option C, that is isotonic normal saline has to be administered. The rationale clearly I have mentioned here. Okay, for administering, why to administer isotonic normal saline? In order to maintain the blood volume, blood pressure, and renal perfusion, adequate renal perfusion. That's all. Okay, always understand the concept, guys. Okay, so third question is, during hemodialysis, a patient complains of severe headache. Hemodialysis is going on. During hemodialysis, patient is complaining headache, nausea, blurred vision. The nurse notes that BP has risen from 130 by 80 to 190 by 110 mmol of mercury. Within minutes, this BP changes, vital changes happening. Okay, see, these are all the classical sign of cerebral edema, guys. Increase intracranial pressure. You can ask one question, sir. The patient is undergoing hemodialysis. How it is possible for getting the cerebral edema, increase intracranial pressure? What is the rationale behind this? The rationale is, understand the concept. See, during hemodialysis, we are removing the blood from our body. While removing the blood, most of the solutes are coming out. Solutes are small particles like, sodium, potassium, electrolytes, toxic substance. Everything is coming under what? Solutes, and it is coming out. Okay. From the body, the solutes will come very easily, but from the brain, the removal of the solute, it will take more time. Okay. So this is the logic. See, from the body, from the blood which is present in the body, other than the head, remove the brain. Okay, other than head or brain, all other parts of the body where the blood is present, it will easily come out. The solutes which is present in the blood will easily come out, but the solute which is present in the brain, the fluids, blood which is carrying the solutes in the brain, it will not remove the solute very fastly. Slow removal of solute will be there in the or from the brain. Understand the concept? From the body, the solutes will remove very fastly, but from the brain, the solutes will remove slowly, gradually. Okay, fine. So during hemodialysis, fast removal of solutes from the body, but from the brain, gradually it is decreasing. So on the whole, what I want to say is there is a difference in the concentration. After starting hemodialysis, the concentration of the body fluid is going to be less, but the concentration of the brain, the solutes which is present in the brain is high. Okay, because it will gradually reduce, slowly reduce. Okay, so this concentration variant, it will cause what? Shifting of fluids from the lower concentration body fluid to the higher concentration brain. Very simple. Fluid is moving to the higher concentrated area. Where is the higher concentration? The brain is having higher concentration and the body is having low concentration. So from here, the fluid is shifting to the brain. Because of that, cerebral edema will happen. Whenever there is a cerebral edema, ICP is going to be increased. Whenever the ICP is increased, the related signs will be there. What are the related signs of increased intracranial pressure? Headache, restlessness, nausea, hypertension, all those things will happen within a minute. So within a minute, there is a change in the blood pressure and all these headache, restlessness, nausea, these symptoms are present means during hemodialysis, it shows the patient is suffering from disequilibrium syndrome. There is a disequilibrium between the brain and the other part of the body. Which disequilibrium? Solute disequilibrium is there. That's why shifting of fluid from the body to the brain causing cerebral edema and increase in the intracranial pressure. So that is the reason why there is a cerebral edema. So for this question, which is the right answer? Dialysis disequilibrium syndrome. There is a short form also, DDS. Okay, DDS. You have to be very careful in solving this kind of questioning. So you should know what is disequilibrium syndrome and what are all the symptoms it will happen during the disequilibrium syndrome. If you have this concept, easily you can solve this question. The next one is, a patient with CKD on hemodialysis reports dizziness, chronic kidney failure, one side. Because of chronic kidney failure on hemodialysis, the patient is getting some symptoms like dizziness, muscle cramp during the session. Okay, the nurse notes that rapid drop in the blood pressure. What is happening? Rapid drop in the blood pressure during hemodialysis. Okay, so what is the most appropriate immediate intervention? Increase intrafiltrate rate. What is, sorry, not ultrafiltrate. What is ultrafiltration? See, you know that in hemodialysis, three principles are there. Okay, so three principles are there. The first one is osmosis, which is used to remove the water, excess water or excess fluid. And second one is diffusion, which is used to remove the excess solute. And the last one is ultrafiltration. It is also used to remove excess fluid from the body, but when compared to osmosis and ultrafiltration, ultrafiltration is working under a pressure. So ultrafiltration is more effective when compared to osmosis. This is the concept behind that. Okay, so here, if you are increasing the ultrafiltration rate, again more and more fluid will be removed, again more and more BP drop will take place. So in order to avoid that, we should not increase the ultrafiltration rate. Okay, so the first option is wrong. Second option, stop dialysis and lay the patient flat. Yes, obviously the patient is having hypotension, so make the patient to lie down in flat position in order to get adequate cerebral perfusion and also clamp the or stop the dialysis. Stop the dialysis. So that is the right answer. Option B is going to be the right answer. Give oral fluid, it is going to help, but it is not an immediate management. Okay, immediately it will not going to normalize the blood pressure. We have to administer the fluids, stop dialysis, make the patient to lie down in flat position so that the cerebral perfusion will be there. Okay, administer potassium supplement. Why? Muscle cramp is because of loss of calcium, not because of potassium. Okay, so no need to think about potassium supplement. So at last, the right answer is going to be option B, that is stop dialysis and lay the patient flat. Okay, fine. The rationale I have given here, please go through this. Okay, the fifth question is, a patient undergoing peritoneal dialysis reports cloudy outflow of fluid. See, till now we have discussed about hemodialysis and now we are going to focus on peritoneal dialysis. See, in peritoneal dialysis, one important concept you have to remember, guys. One exchange, it is equal to a inflow time, dwell time and drainage time. One exchange is equal to, or one cycle is equal to inflow of the dialysis fluid and dwell time. Dwell time means how long the fluid is going to stagnate in the peritoneal region. That is called as what? Dwell time and drainage. These three concepts, please remember that. Understand? Fine. So that is called as a exchange cycle. So what is the question asked here? A patient undergoing peritoneal dialysis reports cloudy outflow. See, always you know that cloudy means there is some infection and inflammation. If there is a pyuria, pus in the urine, means there is infection and inflammation either in the kidney, that is pyelonephritis, or in the bladder. Okay, so there is an infection and pus formation is there, means pyuria. There is an infection and pus formation in the peritoneal region. That's why there is a cloudy outflow of the fluid. Okay, apart from that, the patient is also having low grade fever, abdominal pain. All those things will make you to think about what? Peritonitis. It is a simple direct question. Okay, so catheter obstruction will not cause these things. Peritonitis definitely cause cloudy fluid and fluid overload and exit site leak. These are all not at all related. Okay, the next one, question number 6, a post-operative patient on aminoglycosidase antibiotic. Very important, repeatedly asked question. Please remember that. A post-operative patient, it is on aminoglycoside antibiotic, develop decreased urine output and increase in the creatinine level. As you all know that what is the normal creatinine level? 0.6 to 1.32 mg per deciliter, right? Fine. But here they said that within 3 days, the creatinine level is increased after starting the antibiotic. That is the important key point. Which antibiotic? Aminoglycosidase. As you all know that aminoglycosidase is what toxic? Nephrotoxic. Clearly, I have mentioned here, aminoglycosidase are nephrotoxic and it will cause what? Acute tubular necrosis. Okay, so whenever the patient is going for acute tubular necrosis, within 3 days or within 2 days after starting the aminoglycosidase, you have to think about nephrotoxicity caused because of aminoglycosidase. Okay, in this condition, the urine output is going to get reduced because of what? Damage to the tubules. That is called as what? Acute tubular necrosis. So for this question, the right answer is going to be what? Option B, that is acute tubular necrosis. Because of acute tubular necrosis, tubules are present inside the kidney. So the cause is going to be intrarenal. That's why here it is mentioned intrarenal. See, okay? So intrarenal acute tubular necrosis will cause decreased urine output. On the whole, the main etiology is after starting aminoglycosidase, this acute tubular necrosis happens. Because of this, decrease in the urine outflow happens. That's all. Okay, fine. The next one is a 70-year-old man with BPH, benign prostate hypertrophy. Okay, always BPH means immediately most of the points should come into your mind. That is prostate specific antigen is the marker we have to check, and also Cowdy catheter. Cowdy catheter is same like Foley's catheter, but the tip will be little curved like this, like this. Okay, that is called as Cowdy's catheter. It is easy. This Cowdy catheter is useful to insert easily in the urethra. Okay, after BPH. So in BPH, Cowdy catheter is commonly used. Okay, fine. And the TURP, the surgical management for BPH is TURP, transurethral resection of prostate. Okay, so these are all the repeatedly asked question already came in the exams. So let's see what they have asked here. A 70-year-old man with BPH reports severe suprapubic pain and inability to void for last 10 hours. Because of BPH, you know that BPH, prostate gland enlargement will be there. In between the prostate gland, urethra will be there. So if the prostate gland is enlarged, it will compress the urethra. So urine output is going to get affected. Okay, so we have to maintain the patency of the urethra. Okay, fine. So here, because of BPH, the urine output is affected for last 10 hours. So what we supposed to do now? We have to insert Cowdy catheter, but the Cowdy catheter option is not there. That's why I have selected Foley's catheter. The Cowdy catheter looks same like Foley's catheter, but the tip will be curved. That's all. Understand? Right? Okay. So the next question is a patient with nephrotic syndrome. See, nephrotic syndrome, very commonly asked question. See, nephrotic syndrome means immediately you have to think about what? Signs and symptoms. Hyperproteinuria, hyperproteinuria, hyperlipidemia, weight gain, edema, patient is prone for infection, most commonly seen among the children. Always keep the children in the isolated room because of prone for infection, right? And antithrombin 3 is also a protein. It is also going to excrete in the urine. So more prone for bleeding. Okay, all these things should come into your mind immediately after seeing the word nephrotic syndrome. Okay, fine. A patient with nephrotic syndrome present with severe edema, frothy urine. Why frothy urine? Because protein is excreting excessively in the urine, and also hyperlipidemia is there. So frothy urine is there. Weight gain. Laboratory report shows that serum albumin level is 2 grams per deciliter. What is a normal serum albumin level? It is, I think, 4 up to 8. Right? Fine. But here the serum albumin level is very, very less, and urine protein level is only 4 grams per day. No, 4 grams per day is very, very high. See, what is the normal urine protein? 150. Less than 150 mg per day is normal. Less than 150 mg per day is normal. But here the urine protein is 4 grams per day. Okay, it is very high. Less than 150 mg. That is normal, but it is coming in grams. It is high. So, on the whole, what is the pathophysiological cause of edema? Why there is a edema? This is the question. Why there is edema? Options, let's see. Sodium retention, hypoalbuminemia, cardiac failure, dehydration. 4 options they have given here. Okay. So, sodium retention, hypoalbuminemia, cardiac failure, dehydration. See, as you all know that protein is excessively excreting in the urine. So, in the blood, the protein amount is going to get reduced. So, what is the function of albumin in the blood? Absorbing the fluid inside the blood and maintaining the blood volume. That is the function of the albumin in the blood. But here the albumin is excreting out. So whatever the fluid which is present inside the blood is going to leak out. Okay, so it is causing the edema. So you can see the right answer is going to be option B, that is hypoalbuminemia. The albumin is not there in the blood, so the fluid, the plasma part of the blood is leaking into the intracellular and interstitial space and causing the edema. Question number 9, a patient on continuous renal replacement therapy, CRRT, immediately what you have to think? See, already one question came related to CRRT. Which is the best dialysis method? Hemodialysis, peritoneal dialysis, or CRRT? And the right answer is going to be CRRT, continuous renal replacement therapy. Why? What is the reason behind that? In hemodialysis, disequilibrium syndrome complication will be present. Already I have explained very clearly about the dialysis disequilibrium syndrome, right? So, in hemodialysis, disequilibrium syndrome is there, but in CRRT, disequilibrium syndrome will not be there. Why? What is the reason behind that? In hemodialysis, we are removing the fluid. Rapid removal of fluid will be there. Okay, the fluid we are removing is very, very rapid. In a single prick over the fistula, nearly 600 ml of blood is going to come out. But in CRRT, it is not like that. It is commonly used for bedridden patient, critically ill patient. Continuously 24/7 dialysis will be there for the patient. Okay, that is called as what? CRRT, continuous renal replacement therapy. Okay, so in this condition, disequilibrium symptoms will not be there, syndrome will not be there. Okay, so which is the best dialysis? CRRT, continuous renal replacement therapy, is the best method. So this is also a question already asked in the exam. So for this patient, usually hypotension will not be there because slow and steady removal of blood is there. But suddenly in this question, what they're asking is, this patient also develop hypotension, very, very less, that is 80/40 mm of mercury. It's a severe hypotension. Okay, and also to compensate that, tachycardia is also there. So what should the nurse do first? This is the question, guys. What should the nurse do first? Okay, so continue dialysis. No, again further here means the hypotension will take place. Stop ultrafiltration temporarily. Yes, obviously we have to stop the ultrafiltration to prevent the hypotension. As I mentioned already, ultrafiltration is the best method to remove excess amount of fluid from the body. If you are removing excess amount of fluid from the body, the patient hypotension will become severe. In order to reduce that, you have to stop the ultrafiltration. Okay, so that is the right answer. Administer diuretics. Already hypotension is there. If you are administering diuretics, further hypotension will take place. So you should not administer the diuretic. Increase dialysis flow. Same thing is happening. If you are increasing the dialysis flow, again hypotension will take place. At last, which is the right answer? Option B, that is stop ultrafiltration temporarily. Okay. So the next one is, during hemodialysis, the alarm sound for high venous pressure. High venous pressure. Okay. And the nurse notices no blood flow in the venous chamber. No blood flow in the venous chamber. What is the first nursing action? What is the key point in this question? During hemodialysis, the first point is hemodialysis. High venous pressure alarm is means coming. Okay, high venous pressure alarm is there in the hemodialysis. Okay, so immediately what the nurse has to think. Always remember this, guys. This is a direct question already repeatedly asked in the exam. High venous pressure chamber is there means immediately you have to think about kink in the tubings. That tubings which is present in the dialysis machine, there might be a kink. Okay, so immediately you have to look into it. Okay, so the same thing they have mentioned here. Flush the saline? No. Check for clotting and kinks? Yes, obviously we have to check for clotting and clotting and kinks in the tubings, right? So that is the right answer. And stop dialysis immediately. First you have to check for the clot and kink, and then you can stop the dialysis immediately. Increase the blood flow rate? No. So the answer which is related to question number 10 is only B and C. Only B and C. Among this, the priority is option B. First, we have to check for the kinking or clotting in the tubing, and then if it is present, you have to stop the dialysis. Okay, fine. The question number 11, a 60-year-old CKD patient on erythropoietin therapy present with headache and BP 180 by 100 mm of mercury. What should the nurse do next? You know that kidney is the one, see, two organ which is producing the erythropoietin, guys. Already you guys know that. Already I have explained in previous videos also. The erythropoietin is very, very essential for the production and maturation of RBC. Please remember this. And where it is produced, erythropoietin, where it is produced in two organs. The first one is kidney and second one is liver. In the kidney, interstitial fibroblast cells are there. It will produce the erythropoietin. And in the liver, perisinusoidal cells are there. It will produce the erythropoietin. Okay? So on the whole, liver and the kidney both will produce what? Erythropoietin. Okay, fine. I have said the function of erythropoietin also. Suppose if the patient is having kidney failure, whether it is acute kidney failure or chronic kidney failure, whatever it is, erythropoietin secretion is going to reduce. If the erythropoietin secretion is reduced, what will happen? RBC production, maturation is going to get reduced. In this condition, we have to administer erythropoietin from outside. Erythropoietin injections are available. We have to administer from outside. Okay, guys, fine. So same thing they have mentioned here. A 60-year-old CKD patient on erythropoietin therapy. Okay, erythropoietin injection is going on. Present with headache and blood pressure is 180 by 100 mm of mercury. See, one concept, please keep this in mind. Erythropoietin always cause increase in the blood pressure by increasing the hematocrit level. Excess production of RBC will cause increase in the hematocrit, and also it increases the blood volume. It leads to increase in the blood pressure. Okay, so one word, please remember, erythropoietin will cause what? Hypertension. So you have to monitor the blood pressure regularly. So answer B, hold the dose and inform the physician, is the right answer. Erythropoietin dose has to be hold and informed to the physician. And next question is, a patient with pyelonephritis complaint of flank pain, fever, dysuria. Flank pain is also, flank region is also called as costovertebral angle. Costovertebral angle. This question also, image-based question also already asked in the exam. Costovertebral angle and flank region, where the kidney is located. Where the kidney is located, the anatomical position of the kidney is T12 to L2. T12 thoracic 12 to L2, lumbar 2. Okay, so in this area where it is present, kidney is present, and as you all know that right kidney is slightly lower when compared to left kidney because of the occupancy of liver. These things are very, very basic. Okay, fine. So pyelonephritis, infection, inflammation which is there in the kidney parenchymal cells. Okay, so this patient is having flank pain, fever, dysuria, and after 48 hours of antibiotic, urine output further decreased. Usually what will happen? Antibiotic we are starting means the recovery should be there. But here, after starting antibiotic, the urine output is decreasing, creatinine level is increasing. It shows the antibiotic is not at all working on the kidney. It is not at all sensitive to the kidney bacteria or kidney virus, whatever. Understand the concept? So, what we supposed to do now? What does it indicate? This is the question. Resolution of infection after starting in antibiotic, if the urine output is increased, creatinine level is decreased, resolution of infection we can consider, but here nothing happened. So eliminate the first option. Worsening renal involvement. Yes, obviously the renal condition is worsening. So option B is the right one. Option C, bladder outlet obstruction. Bladder outlet is obstructed. No. Fluid overload. No. So here the right answer is going to be option B, that is worsening the renal involvement. Option B is the right answer, guys. Okay. So hope we have completed 12 questions, right? So this is a part 1, and part 2 video, the next 12 questions or 13 questions, whatever it is, the discussions will be there. Okay. So please watch this video completely, understand the rationale, understand the concept. If there is any doubt anywhere, watch the video again and again. Still you are having the doubt, the clarification is not there, then drop your message in the comment section. I will explain it. Okay. So part B video, which will be there after a few days. Okay. So most probably in the next week, I will be releasing the part B videos related to renal system. See, these questions all taken from the NORCET and all the competitive exam question papers. Okay, so if you are thorough in this type of questions, easily you can solve the question paper very easily. So watch the video again and again, share with your friends. Okay, and if you want to clear your attempt in the first session, please join our Métier International Academy. As I mentioned already, Delhi branch and Pondicherry, Tamil Nadu branch is also there. If you want to join offline, you can join offline. Otherwise, if you want to join online, you can join online. It is up to you. Okay. So thank you very much for watching the video, and all the best for your upcoming examination. And wait for the part B video. Watch it and understand the concept. Thank you very much for watching the video, guys.